So yeah, I'm a Professor of Addiction Psychiatry at King's College London, and also an Honorary Consultant Addiction Psychiatrist at South London and Maudsley. So I was going to go slightly further back than 2019, because when I was preparing this, I found a slide set from 2015 when I spoke to Our Healthier South East London. And I was quite surprised that this is still actually a good slide and still applies. So what I thought I'd do is I'll take you through a little bit of what I said in 2015 and then see how far we've gone in the last 8 years. So this probably isn't going to be visible if you're much further than about 2 yards away. But what I said back then was alcohol-related health and other harms are increasing across England. That's still true. The costs to the NHS are high, and the average borough in South London is likely to face health costs of around 14 million, crime costs 47 million, and costs to the economy through reduced productivity of about 30 million. That's still true, but of course we need to factor in inflation and also rising prevalence. So these costs are likely to be even higher now. 40% of attendances at King's and St Thomas's emergency departments are alcohol-related. Alcohol-related inpatients admissions have doubled in the past 8 years, and in mental health care, the prevalence is about 50%. So all this is still true. And the final conclusion on that slide is measures to address this burden, both within the NHS and more broadly in public health and social care and criminal justice, are well evidenced, but implementation is poorly applied. So this is still true. So this is just showing you the rise in alcohol-related hospital admissions from 2003-04 through to 2019. When I was speaking before, we were here in 2015, and you can see the prevalence rate has continued to increase since then. It's partly driven by an age cohort effect of baby boomers who are now becoming unwell with their drinking. They haven't reduced their drinking to the same extent as previous generations did at that age. We also have increasing health inequalities, and I'll show you the impact of inequalities on alcohol-related harm in a moment. And of course, we've already heard about cheap alcohol, which is a big driver behind the whole thing. And of course, you know, in England, the government has steadfastly refused to consider minimum unit pricing, although did do a slight tinker with the alcohol duty at the last budget. So these are the alcohol-related hospital admissions by boroughs in South London. This is the rate of admissions per 100,000 along the bottom here. So you can see Lambeth and Southwark are at the top of the alcohol-related hospital admission prevalence rate. Richmond over there at the lower end, probably reduced when the Rolling Stones moved out. And everywhere else is kind of somewhere in between. But what you see from this slide is that if you look at that against index of multiple deprivation, there's actually like a 0.74 correlation. So the higher the deprivation index, the higher the prevalence of alcohol-related hospital admissions. And this is also true if you drill down into a borough. So if you look at parts of the borough that have the highest deprivation, they also have the highest rates of alcohol-related hospital admissions. So what's needed? Well, this is my 2015 view of what was needed. So I've said, first of all, adequate provision of specialist alcohol treatment. And I don't know if you know, but I mean, that only about 20% of people with alcohol dependence access treatment in a typical year. And that's true across the country. There's some variation between different parts of the country, some variation in South East London in those rates. But this is still true. There hasn't really been any major expansion of alcohol treatment provision in the time since I last discussed this. So in fact, if anything, what we've seen is a reduction in the numbers of people with alcohol problems getting into treatment. The second one was making every contact count. And by that I mean adequate implementation of alcohol screening and brief intervention. And that's both in the hospital setting and also primary care and other settings. Thirdly, adequately funded alcohol care teams in acute and mental health care. And at the time, 2015 or around then, we didn't have fully operational alcohol care teams in our two main hospitals in King's Health Partners. And fourthly, targeted interventions for alcohol-related frequent hospital attenders. And I'll explain a bit more about this group, but there's a relatively small number of people who account for the bulk of the alcohol admissions by virtue of complexity and repeated hospital admissions. So around this time, about 2013, we'd just launched an alcohol strategy for King's Health Partners called Good Health. And those were the four top things that we recommended implementing in 2013. And within the strategy, we looked specifically at what King's Health Partners could do to try and address this problem. So what went well 8 years on? Well, I'm delighted to see the Vital Five is alive and vital and expanding, you know, because it was originally envisaged as a hospital public health approach, but obviously it has equal applicability in primary care and other settings. So that's good. 7-day alcohol care teams in both King's College Hospital and St Thomas's, or GSTT. At the time we developed the strategy, there were only a very small number of alcohol liaison nurses in the two hospitals. We now have two optimised alcohol care teams, which are really a beacon of good practice in the UK. Alcohol Assertive Outreach team in Lambeth, we managed to get funding from the guys in St Thomas's Charity initially to set this up, to target the most frequent hospital attenders with alcohol problems. And subsequently, it's become sort of adopted into core activity within South London and Maudsley, but serving all of the hospitals and all the community of Lambeth and Southwark. And as a result of this, we have evidence of impact on alcohol admissions and costs, which I'll show you now. So the Assertive Outreach team, I'll sort of focus on this one. I'm more qualified to speak about this than I am about the alcohol care teams, but they've also had a significant impact. So the Assertive Outreach treatment, it's really been adopted from caring for people with severe mental illness and difficulties in engaging with treatment. So we adapted it to work with people with primary alcohol dependence, who often have other issues, mental health, physical health, and so forth. So it's a much more intensive approach than is normally provided in standard addiction care. There's regular persistent contact, assertive engagement, home-based interventions, a patient-led agenda. In other words, we're not going in saying, you know, you need to stop drinking. We're saying, what can we help you with? And then gradually working with people to see if we can help them to change the drinking behaviour, which is underlying a lot of their problems. The minimum contact is at least weekly. Sometimes it's much more frequent than that, and it's persistent for at least 12 months. So that's how we adapted assertive outreach for alcohol. And we particularly have targeted alcohol-related frequent hospital attenders, who are people who have 3 or more alcohol-related admissions per year to either King's College Hospital, GSTT, or SLAM, and sometimes they actually have been to all 3 and collected the full set. And we identify them through their electronic hospital records. We ask every month for a copy of, you know, who's been admitted 3 or more times in the previous year. We then approach them, and try and engage with them in their homes or local communities. So we've done quite a bit of research with this population now, and we know a few things about them. One is that they have multiple unmet physical, mental, and social care needs. And some of them are amongst the most complicated people I've actually worked with in my career. They rarely access community addiction services, or if they do, they don't generally engage very well with them, and they tend to fall out of treatment. They also feel very stigmatized and socially excluded, and often they're met with sort of a bit of a heart sink feel when they come into hospital yet again with another episode. They also, although they're 9% of people with alcohol dependence, they account for nearly 60% of all the admission bed days. So there's a small group of people in the community of those with alcohol dependence who account for the bulk of the activity in hospital. And if you look across the whole of the UK, they account for about 1.4 million bed days. So it's a huge cost to the NHS. So one way of looking at the impact of implementing assertive outreach for this group was to look at the hospital admissions before and after introduction of assertive outreach. And the reason we were alerted to this was one of the managers at King's College Hospital phoned up one day to say, we're trying to make a business case for the alcohol care team. Have you got any idea why the alcohol admissions are reducing at King's? Which is, of course, good news, but not if you're trying to write a business case. And so what we had was a 24% reduction in alcohol admissions because we targeted their most frequent attenders and managed to divert them into more appropriate care. And this is a slightly complicated slide if you're not familiar with health economics, but essentially we did a cost effectiveness analysis of assertive outreach versus standard care. So we had a randomized controlled trial. Half the people were offered assertive outreach, the other half were offered care as usual. And we compared their clinical outcomes and also their costs over the following 12 months. And basically this diagram just shows you that assertive outreach improves quality of life whilst at the same time saving money. So if you're in this bottom right quadrant, which you can see we mostly are, then that's the cost impact. We reckon it's saving about £10,000 per patient. And another economic slide, it shows it's 90% more cost effective than standard care. So the assertive outreach is a good news story. I think the alcohol care teams being established is another good news story, or two good news stories in one. The Vital Five is good, but what could have gone better? I think it's fair to say there's been a lack of momentum on alcohol public health policy originating from the government. So the last time the government looked at alcohol in a policy way was back in 2012, I think it was. That strategy has now effectively lapsed. The only thing that was in it was minimum unit pricing, which about 2 weeks later was dropped. So really there's not been a great deal happening in a policy sense with alcohol, apart from Department of Health and Social Care was promoting the development of alcohol care teams, which is still going on around the country. There's also been a fall in alcohol treatment numbers, down about, I think, 20% from the peak, which Public Health England had a look at and reckoned that a lot of this was about combining drug and alcohol treatment. Some of it was about loss of expertise, specifically in alcohol. There are a number of factors, so I think that is having a small impact. In fact, if you look at the latest OHID figures on alcohol treatment, it's beginning to go back up again. So next one, lack of alcohol inpatient treatment facilities. So during the course of this, the SLAM inpatient alcohol unit closed down. We had Brook Drive, it's also closed down. So up until recently, I think mostly people who needed inpatient care were being referred out of the borough to places around the country, and in quite small numbers. But recently, St Thomas's has got a new inpatient facility. I don't know the latest on that, but that's a good development. Bringing in alcohol expertise to help people while they're detoxifying in hospital. Another thing that could have gone better is the focus was mostly on acute care, but there's actually high unmet need amongst people with comorbid mental health conditions. And I think, Emily, you might be talking later, I don't know, about initiatives within SLAM to try to, improve in-reach of alcohol care to people with co-occurring mental health problems. And the other thing to say is the improvements have largely been confined to Lambeth and Southwark. But, given that we've got so much knowledge now and so much evidence which has been generated within Lambeth and Southwark, we should really be trying to spread it across the whole of South East London so that everybody in South East London can benefit. So just one last thing before I finish, which is, if you're having to sort of weigh up where should the money be best spent, if there is any money, that is. And I'm just going to show you some data from 4 trials that we've done, 4 clinical trials, looking at impact of interventions on hospitalization for people with alcohol problems. And we've got the SIPS primary healthcare study, ESOPs, which is older adults, both brief intervention studies. What you can see is they have hardly any inpatient events before intervention and slightly less after. So although brief intervention does have a significant effect on reducing drinking and reducing hospitalization, it's actually quite a marginal effect. Whereas if these 2 studies are both assertive outreach with complex people with alcohol dependence, and you can see they have a lot of admissions before intervention, and they tend to reduce quite significantly after intervention. And that's because they're starting with a very high level of service use, so they have a lot of admissions. So you can therefore have quite a big impact by doing an intervention. And if you just put that into some sort of context, so the brief interventions we estimate cost about £12 per patient to implement, just in terms of staff time, materials and so forth. And Public Health England originally had an ambition of delivering screening and brief intervention to 900,000 hospital inpatients through their Sequin. And if they were able to implement that effectively, their own figure is that that would save them about £11 million. So 900,000 brief interventions save you £11 million. By comparison, our data shows there's about 54,000 alcohol-related frequent attenders in England, about 324 of them in Lambeth and Southwark. But if you successfully intervened with those 54,000, it would cost about 11,000 per patient to deliver, but it would save across the country about 590 million. So essentially, because they're very high need, high cost, there's more scope to save money. So I think you just need to bear that in mind, when weighing up different options. And also to say, all of our brief intervention studies, we've done about 6 or 7 now. In each one of them, we had extreme problems trying to implement it in any of the settings that we worked in, whether it's primary care, emergency departments, probation services. So they're extremely hard to implement. It can be done, it should be done, but the cost savings are not going to be huge. We could do with a renewed focus on alcohol harm both nationally and in South East London. So I'm really glad that you're pushing at this door again. We need to focus on implementing the most cost-effective interventions. Money is tight, so when it's tight, you need to spend it wisely and on the things that are going to bring the biggest returns. What I've said also is actively identifying and treating people with alcohol dependence is a highly cost-effective public health intervention. Public health isn't just about upstream, reducing the harm in the first place. It's also treating people actively when they have developed problems. The greatest savings can be achieved with high need, high cost alcohol frequent attenders. But of course, people with alcohol dependence are also up the scale in terms of costs compared to hazardous drinkers. There should be a greater focus on people with alcohol and mental health comorbidity. So I'm glad that SLAM is now having a look at ways of doing that. Screening and brief intervention is hard to implement and has limited cost savings. But, if you use that as a way of identifying people at an early stage and referring them into effective treatment, then I think it's probably worth it, in itself. Even if it doesn't have a huge impact on costs, it might actually be a gateway for people to get into specialist treatment. I think that's it now. Thank you.